When it comes to hormone replacement therapy, there are many different protocols. We see huge variation between dosages, delivery forms, and types of hormones used. What works for one person may not work for the next person. And what one practitioner sees working best may not be what others see working best. And so today, my distinguished guests and I are going to explore the different schools of thought around estrogen replacement therapy. First and foremost, thank you to all of you for being here and open to discussing this on my podcast. I appreciate and admire each and every one of you. You guys are all just the biggest trailblazers when it comes to hormone replacement therapy and menopause awareness. So I appreciate everything that you've done for us women in your time and in your careers. So welcome everybody, and I want to just dive right in, starting with you, Dr. Berkson. We started using estrogen replacement therapy derived from pregnant horses' urine, which posed some issues. Now we have the option of bioidentical forms of HRT. Can you just share with us the history, first of all, of bias and why was it brought into use?
Okay, first of all, I want to thank you for putting this on, and I want to say that I appreciate all the esteemed guests, and I look forward to this thoughtful, kind conversation between all of us. How great to have many opinions and keep it marvelous. So my mentor, Dr. Jonathan Wright, was the first person to write the first bioidentical hormone prescription, and he really did it when he was thinking he was going to write a script for Premarin, which is conjugated equine estrogen, or from pregnant mare's urine. And the patient herself, which a lot of things come from, said, can't you write me a natural prescription of natural hormones, not from a pregnant horse? So he wrote the first script for Triest. That was the first bioidentical hormone, all three parent estrogens, estrone, estradiol, and estriol. And over the years, as we started to learn more about which hormones signal which receptors and the actions of those receptors, because he really came up with this before Elwood Jensen had discovered ER alpha, and that ER alpha signals that, and it's called ER alpha because it's the first estrogen receptor, alpha, the first letter in the alphabet, and it signals politically correct 50% of the time ER alpha, and the second 50% of the time, the second receptor discovered, so-called beta, ER beta. So Dr. Wright first started out with 3 estrogens, and then they discovered that estrone mostly signals ER alpha. And ER alpha, when signaled, signals growth most of the time, and ER beta, when signaled, signals controlled growth most of the time. So in 1995/6, when Yanaki Gustafsson first discovered the second receptor, he presented his paper with a picture of the Justice scales. So he said, ER alpha and ER beta, their balance in tissues is what protects tissues. So you have to think of it as signals to both being balanced, but estrone, thinking it mostly signaled ER alpha or growth, got lost by the wayside. So Triest graduated on to Biest. And then with the work of Henry Lemon, which I know that Dr. Rosensweet is going to talk about, he actually did in vitro studies where he exposed animals to chemicals that normally cause tumors or mammarogenesis, DMBA. If he pre-exposed those animals to estriol, they would have less tumor formation, or if he treated them after they formed some smaller tumors, he could show tumor regression. So he started publishing articles that estriol was breast protective against breast cancer, and thus Biest sort of solidified its way early on in the early bioidentical hormone community.
Wonderful. I knew you would explain that very well.
Okay, thanks.
Now, you personally use Biest primarily in your practice. Is that correct, Dr. Berkson?
Yes.
Yes. And what ratio do you like? Because I know typically it's in like an 80% estriol with a 20% estradiol.
I really treat the patient more than the ratio. You know,
Yeah.
we have the old sentence, treat the patient more than the laboratory. I think I actually treat the patient more than the ratio. And because I do so much breast cancer, I started a functional breast cancer program at Dr. Perlmutter's old clinic. I just finished that contract. And I had breast cancer 33 years ago now and have been on hormones. So in those patients, I give a higher dose of estriol because of its anti-tumorigenic activity. So I often do 50-50. In patients where I'm putting the toe in the water, I might do 80-20 or 90-10. But in other patients, I'll really think of the ratio more based on their individual situation. So I do much larger doses of estriol in myself, for example, than I do estradiol.
Okay. So basically, estriol, it's seen as very breast protective, which is why it's been included into estrogen replacement therapy. Now, Dr. Taguchi, you have a history of working with breast cancer patients. You are an oncologist. Can you discuss whether or not estriol is breast protective, like the research is showing?
Like the research is showing. What I can tell you though is I do know that estradiol, when it activates ER alpha, it makes an ER beta. So we still need estradiol for the right amount and the right linkage, et cetera, G coupling on top of it to make everything work. I'm sorry about the background noise, but
I can't hear it.
Okay, that's
Good.
great.
Yeah.
Okay. So I know you have to have the estradiol to make the beta receptor. So
Okay.
and you need to have enough of it, and how that all couples and links, et cetera. It's important. And it's not just estriol, estradiol, estrone. Estradiol metabolizes into many different things, and they're all good. They're all good hormones, and they all function normally in the reproductive woman. So in the oncology research, I don't think even estriol is what might be considered for a vulvovaginal help, but not. I don't think it's even looked at in medical literature in clinical oncology at this time. I know that Joanne Manson, when the Women's Health Initiative was started, apologize for that. When Joanne Manson, she wanted to study transdermal hormones and something, biased, estradiol, anything, and she could not come to a conclusion on what to study, what ratio, because it was all over the map. So there were opportunities for these things to be studied, but because there was not consistency and consistency in how things were prescribed amongst physicians, she did not go through with that.
Mm-hmm. And in your practice, because now you mainly just work with women in hormone replacement therapy, correct?
Yes, right now, yes.
Yeah. And so in your practice, are you using biased, or are you primarily using estradiol?
When I was trying to figure out hormone replacement therapy, this was years ago, women, when they're reproductive, they have a certain pattern when they're reproductive of estrogen and progesterone. And, there's reasons for the highs and the lows of the hormonal cycle.
Mm-hmm.
Okay. Then we have, so that's on one template for, human existence. We have our pregnancy existence, we have our breastfeeding existence, and then we have our menopause existence. And so it's normal to have no hormones in menopause, right? And so if you're going to replace something, how are you going to replace it? And so I was always of the mindset, it made more sense to replace it like we had it reproductively. That is also going for the same levels like we do in thyroid hormone replacement. So the TSH normalizes and clinical symptoms are addressed. And that, and so if we're going to replace hormones in postmenopausal women in general, I went with the template, made the clinical template of using the reproductive template of health for menopausal women, although we don't really have a good template, right? There's nothing is right. So, but I've never, I don't write for biased. So I never understood why, because estradiol can convert to estrone, it has to be, which is considered a bad estrogen, whatever, but it's the parent of estriol. So it's just something that never made clinical sense to me in terms of the, you know, because it's going to happen anyway.
Mhm. And just the natural ways our body normally produces these hormones in our fertile years, you just saw it fit to continue trying to replicate that as best you could in practice.
Right. Yeah.
Yeah. And Dr. Gersh, you are in the same, very similar mindset. You were the first person that, introduced this to me, actually, when you said to me once on an interview, which I'm sure you won't remember because it was years and years and years ago, but you said, why would we try to mimic pregnancy in menopausal women? So can you explain that and kind of how you came to thought on what we should be replacing estrogen with?
Well, in alignment with Dr. Taguchi, nature is always smarter than us. And it makes absolutely no sense to me that we would try to create a hormonal existence that never exists in any woman at any stage of life ever. So estriol is made, and Dr. Taguchi alluded this, estradiol is the dominant estrogen of the reproductive years. It's the estrogen that is coming out of the ovary into the bloodstream that circulates through the body. Estradiol, which has a letter E and a number 2, estradiol has the ability via enzymes to convert to estrone, and estrone can interconvert back to estradiol in the right situation as the body needs it. The body is micromanaging itself in terms of its additional estrogen components as needed when you have a healthy woman. And estriol, E3, is also a hormone of the estrogen family that is derived from estradiol in a unidirectional way. Estriol cannot convert back into estrone or into estradiol. So in a reproductive aged woman, estradiol is the ovary produced estrogen, and it lives in a beautiful synchrony and rhythm with other hormones, including progesterone, with the lunar menstrual cycle. And estradiol and its different receptor functions, which includes alpha and beta, and another one that is the G protein coupled estrogen receptor, which we now know has amazingly important effects throughout the body. And I would like, if I have the opportunity, to sort of run through, like, what do these different estrogens and the estrogen receptors do in a healthy female? So I really admire, the idea that you're trying to micromanage estrogen receptors and estrogen types in the body, but we will never be smarter than nature. A woman in the reproductive years is the healthiest she will ever be. So we want to, when we transition into perimenopause, and to me, that is the time when we should initiate hormone supplementation, is perimenopause. We don't want end-stage disease of any sort. And the official definition of menopause as 12 consecutive months without any bleeding is really an end stage in the process of ovarian aging, because that's what it's all about. It's about ovarian hormone production and decline and aging of the ovaries. So we want to initiate hormones early on. And what would we initiate in a perimenopausal woman who is having fluctuating hormones with a general decline, but sometimes spiking up, and sort of a dysregulated axis involving her hypothalamus, pituitary, and ovaries because of the ovarian kind of changes that are happening. So if we supplement with hormones, we're going to supplement with the hormones she's making, which would be estradiol and progesterone, to try to align with the menstrual cycle. And we should continue that, because nature shuts down the hormone production from the ovaries, but the ovarian hormone rhythm and levels and the type of estrogen that's produced is what nature produces to keep women optimally healthy, because fertility, which of course goes away, but fertility is a vital sign of health, and it's a manifestation of having optimal hormones. So now in pregnancy, the placenta makes the hormones for the body involving the estrogen and the progesterone. And the dominant estrogen of pregnancy is estriol. No, that's not an accident. It's because estriol is a more dominant effect on the beta receptor, but it has some effect on the alpha, and it binds less powerfully to those receptors. So you can think of it as a different and weaker estrogen, but it has amazing effects on pregnancy to allow the pregnant woman have an altered immune system so that her immune system has innate immune cells that are like the first attack animals of the body, and they would attack like a pathogen trying to get in the body. Well, the antigens, the proteins of a fetus are not the same as the woman. So you have to modify the immune system of a pregnant woman so she doesn't kill the fetus. And that's why there's this big change in the estrogen components that are circulating in the body, because the downregulation of the innate immune cells is what is happening with estriol, which that also, though, not only keeps the woman from killing her fetus, but it also downregulates her immune system. That's why pregnant women are more vulnerable if they get COVID or the flu or chickenpox. They have worse outcomes because basically you can think of it as an immune modulator. They're downregulating the production of inflammatory cytokines, which is why many women who have certain autoimmune diseases will actually go into something of a remission during pregnancy. But there are many other changes that are happening in pregnancy that increase insulin resistance, change the gut microbiome so that you have a more production and more rapid production of fat in pregnant women. You have more sugar going to the baby. It's a very unique time of life, but it's also a fragile time that women, if they're not healthy, they can have all kinds of gestational diabetes and preeclampsia and hypertension. So the last thing we want is to in any way try to replicate pregnancy in a non-pregnant woman. And estriol is in perfect balance in a healthy woman of reproductive years with estradiol. And the amount of estriol that's normally produced during a menstrual cycle is really small. It's about 7 picograms per mil in the follicular phase, the first half of the menstrual cycle, and it goes up to maybe 11. This is in contrast to estradiol, which could vary, tremendously from like 40 up until like 400, because that's like when ovulation is going to occur. There's a pre-ovulation spike of estradiol. But the bottom line is we are in no way smart enough to be micromanaging receptors and trying to recreate a new physiological state in women. If you start hormones in perimenopause and then you just keep them going at in a cyclic form, you will up and down regulate receptors and turn on and off gene expression, because these hormones are working in this amazing balance involving all the other organs. And if we look at, for example, like Dr. Taguchi mentioned, metabolites. Well, estradiol has metabolites like 2-methoxy estradiol, which actually has its own receptors in the heart to help the heart to create more energy. And the G protein coupled estrogen receptor is throughout the heart and is critical for heart function. And there's never an exclusive only alpha or only beta. There's always a balance between these two, and they interact with one another. They up and down regulate each other. They create each other. This is much too complex for us to think that we can actually figure this out and do better. Now, like if you look at also, there are such things called estrogen-related receptors, and there's a lot of those in the heart. We don't even know what binds to the receptor. It's not estrogen of any sort. But if you don't have estradiol present, then what happens is you don't have that binding and you don't have the incredibly important effects. And we know that mitochondria, which are critically important, have both alpha and beta receptor function, and you have to have it all. I mean, we do not we're not anti-alpha. And it's just unfortunately, but it's oversimplistic to think that alpha is just about growth. Alpha regulates the nutrient sensors in the hypothalamus to help regulate appetite, because metabolic health is what health is all about, which means you have to have a finely tuned intake of energy to match expenditure of energy. And that is so critically important. And you lose appetite regulation in menopause. That's why many women develop dysregulated eating and binge eating. Well, it turns out that alpha is actually the dominant estradiol, the dominant form of receptor. The dominant form of receptor is the alpha on the nutrient sensors in the hypothalamus. But yet, interestingly, the beta is the dominant form of estrogen receptor in the suprachiasmatic nucleus, which is the master clock of the brain that maintains the circadian rhythm. It's a beautiful interaction between all of these different types of receptors. And growth is not evil. If you do not have growth is about like brain-derived neurotrophic factor. It's about growing neurons and synapses in the brain. And you need all these different estrogen receptors activated to maintain the neuroplasticity in the brain. And you need to have growth of the bone. Like, so we know there's a more prevalence of one or another. Alpha is more in the bone, the gut is more beta, but it's not one or the other. It's a mixture everywhere. So it's very complex. And, you know, I really applaud the idea that we, you know, want to do everything best for our women. And I always have a policy, I'd call it, any hormones are better than no hormones. But I just want to do, like what Dr. Taguchi was saying, I want to recognize when are women healthiest. Now, every cell in your body is a different age. They don't know how old the body is that they're inhabiting, because very few cells are the same ones you're born with. When a cell comes into being from the stem cell pool, which is helped to be maintained by estradiol, by the way, and it doesn't know how old the person is. It's genetically programmed to do whatever it's designed to do. And if we can give it the right nutrients, the right hormones at the right levels, in the right rhythms, we can maintain optimal cellular function at every age, so that every woman has the potential to become a super ager, which is you can do everything at 95 you did at 35 reasonably, okay? But you need to have those hormones. Hormones are life itself. And, you know, I just want to, you know, cheer the alpha receptor, the G protein coupled receptor, the beta receptor, and we want them all to be in the right functionality, to work in the organs they're designed to work in, and to that we should step back. And if we're going to give hormones and try to maintain optimal health for like decades and decades, then I think we should just mimic nature and give the hormones that nature gave us during the healthiest years of our lives.
Thank you. Dr. Rosensweet, there's a few things that Dr. Gersh just said that you and I actually talked about when we met last year. You and I hopped on a video conference and talked for a good hour about all things hormones and hormone replacement therapy. And you are the creator of the Menopause method, which I am taking that course. Thank you. And when we were talking, I did kind of run some of these things by you that Dr. Gersh is saying. One being that, you know, in our fertile years, we produce more estradiol than we do estriol. And you said that you actually came across a paper that showed that that's not true, and that we actually produce more estriol. Can you talk about that?
Well, it was the same Dr. Wright who was referencing this literature by an oncologist, Henry Lemon, who was at the University of Nebraska in the late 1960s. And Dr. Lemon did a study of 24-hour urines collected from two types of women that were normal, healthy, regularly menstruating, and also women who had breast cancer. And what he found was that in young, healthy women, on the average, and there's a range, of course, the average amount of estriol was 1.3 times the amount of the sum of the two most potent estrogens, estrone and estradiol. And he also found that in the women who had breast cancer, that ratio was much reduced. There was far less prevalence of estriol. And that was one of the reasons that Dr. Wright leaned towards triest, and then, as Dr. Berkson said, eventually arrived at biest, just to copy nature, which was one of his favorite sayings.
Mhm.
Now, it turned out that Metametrics Lab, and many of people on this call remember Metametrics, they actually funded a study that I conducted in the early 2000s. And I was still using 24-hour urine hormone testing by GCMS. And we actually interviewed 600 young menstruating women to try and see if we could find any healthy young menstruating women. And 100 qualified. These were nursing students. Okay, it was skewed. They're pretty stressed. And we came up with 100 samples and of mid-luteal, regularly menstruating, relatively healthy young women, 20 to 29. And the average amount of estriol was 1.1 times as much as the sum of estrone and estradiol. So I just took that as, okay, this is the way it's done in nature. And more came in, though, over the years. As I studied the menstrual cycle, I saw that there were these two phases. One was a buildup towards possible implantation, a buildup of proliferation in the endometrium to form a wonderful lining for the reception of a fertilized egg. And there was also, much to my amazement, there was also preparation for pregnancy in the sense of preparation for possible breastfeeding that also took place during the first half of a young woman's cycle. And that also is a proliferative phase in which new cells are formed in the breast. Many young women feel a fullness develop as their cycle develops. And that is under the inspiration, shall we say, of estrogen receptor site alpha. And again, estradiol is so critical, a female hormone, oh my God. And then should the woman not become pregnant, then there's the second phase of the menstrual cycle in which deproliferation predominates, much under the inspiration of the estrogen receptor site beta, and that there's actual loss of cells by a wonderfully named process called apoptosis, as the cells disappear. And many women experience that as a less fullness of their breasts in the second half of the cycle or in the early part of menstruating. So just to copy nature, because I felt like that's a good idea to do. I started experimenting with what Dr. Wright originally suggested. He suggested a biased 80% estriol and 20% estradiol. And what I discovered, because we do 24-hour urines on every single one of the women that we treat, that was the most likely and not the only ratio, as Dr. Berkson was saying. But with 80-20, we're going to replicate this 1.3 plus or minus a ratio that occurs in young, healthy women. So that's, but on the 24-hour urine, I can see that maybe this woman does need a little more estradiol so that this ratio does not get too great, so there's not too much a predominance of estriol. So we customize, and we can do that with compounded bioidentical hormones. We customize for each individual woman. About 75% of the women, this is over 30 years, about 75% of them do really well with 80-20. And the rest of the 25%, plus or minus, they really need a more individualized, different ratio of estradiol to estriol. For what purpose? Just to sort of get in the ballpark of what a young, healthy woman does. Does this protect us from breast cancer? This is the bottom line in menopause medicine. God, there's so many moving parts in the development of breast cancer. And hormones are not part of it. Like Dr. Gersh suggested, hormones, replenish hormones for the healthy woman. And my goodness, there's so many different variations possible there. But hormones don't cause cancer, in my opinion. I've dived deeply into the causes of it. And how precise can we be, as Dr. Gersh suggested? Well, how precise can we be with 100 million moving parts of a human being? And we're playing with the most powerful biochemicals, the hormones, but still, we're also we're just estimating what's optimal. But I just believe if we sort of follow nature's original design, we'll do really well.
Yeah, see, and I find that, what Dr. Gersh was saying, that estriol is produced in minimal amounts compared to estradiol and estrone in blood work. And I definitely see that. I mean, I've looked at hundreds and if not thousands of blood work. I've also done 24-hour urine tests, thousands of those. I personally, clinically, I rarely ever see estriol higher than estradiol or estrone. And I always see it being next to nothing. It's always at the very, very low end of range, like 0.1 on blood work. I don't know if maybe serum isn't the best way to test it. But even with my 24-hour urine tests, I don't see it being elevated. So there's some controversy there, right? You're saying that this paper showed that estriol is made in great abundance. Dr. Gersh is saying that no, we don't produce it very much in cyclical women that aren't pregnant. Dr. Taguchi, what do you find with that in your practice? Do you see that estriol is more like higher levels?
To confess, I don't even measure them because I mean,
Right.
I don't use a 24-hour urine to assess hormone. I mean, I use blood work when needed and, intermittently, but I go by what the woman's feeling. So, I mean, I do know that bias definitely fixes hot flashes. I know it can help them sleep. So I know in terms of symptom control, it definitely has an effect. But I just don't use urine testing to alter or change anything, because your urine test, just like your blood test, could be different on a different day depending on what you eat. Because we know that metabolism from estradiol to estrone is affected by DIM and what you eat and how, if you're stressed and all the stuff, it changes all the time. So I've just never been one to adopt the urine testing. I mean, if you're not on hormones, you want to evaluate how the system is. That makes sense. Anyway, but I did want to say something in terms of when in a regular reproductive cycle, when you have that day 12 peak, there's the estrogen really accelerates at a very, very steep rate. And when estradiol is like that, it does different things to the body. And one of the things it does is it upregulates the P53 proteins, as does the progesterone, as starting at the progesterone peak for the woman. So, in terms of, cancer and tumor protection, the body has its own regulation. Plus it has SHBG. So it will monitor itself. And if you had any patients like I have, they've had too much hormones, say they had a bowel obstruction. I've had a patient who called me and just said, these hormones aren't working. I feel like crap. I have sweats and all the whatever it is. And so I did her blood work. And she had a level of 2000, but she also had a bowel obstruction. So that taught me a lot. Like too much estradiol is like having none, because it blocks the self. Okay, the SHBG was high, etc. So it's a very interesting process for me to have that for her, from her. So the body does take care of itself, and there's a million other reasons to have breast cancer. And trust me, I'm gonna try to find. I can find a lot of it now. I mean, when I see somebody with breast cancer, I could find multiple potential contributors.
Yes. Yeah. Dr. Berkson, what are your thoughts here?
Hi there. Well, I love what everybody's saying. It's a great conversation. Thank you for all being in on it. Great. Well, first of all, I was a distinguished hormone scholar at an estrogen think tank, and I got to work with Yanaki Gustafsson, who discovered the second receptor. And he started to pump out multiple papers, at least 15 papers, discussing estrogen receptor beta agonists as one of our own natural chemotherapeutic agents. We have two major natural ways of fighting cancer: signals to ER beta And then the last methylated from you go to parent estrogens, to catechol-estrogens, to methylated estrogens, of which iodine, interestingly enough, helps make these methylated estrogens, besides many other factors in genetics and so forth. And I was just saying growth because to simplify it, it's not like it only does, any receptor only does one thing, but it's all about balance in the tissue. But he has come out with multiple papers saying that any agonist, what signals ER beta, he's got a paper that it's effective in vitro against glioblastoma, one of the most aggressive cell lines we have, against ovarian cancer, against triple negative breast cancer, against ER positive breast cancer. He's got multiple papers. He discovered it in 1996, and 20 years later, 2016, on its birthday, the 20-year birthday of ER beta, he published in a hormone journal, and it was called Update on ER beta. And he said, why aren't clinicians, now mind you, he got wooed from the Karolinska Institute in Sweden, which is their version of Harvard, over to Houston to find things that signal ER beta to treat breast cancer and make drugs out of, that act like estriol, because estriol signals about 85% of the time ER beta. So on his update on the 20th birthday, he wrote this impassioned paper, and he's a PhD scientist. He said, why aren't clinicians using agonists for ER beta? Because it so protects a woman's breast and multiple other cancer cell lines. So this is the gentleman who discovered the receptor. And he also says that both of these receptors are naturally found in nature in multiple tissues. And that's why he had the scales of justice. The balance of these receptors helps maintain the health of these tissues, like our endothelium is just covered with estrogen receptor beta and estrogen receptor diol receptors both. So it's very interesting, but I love that comment from Felice. She'll say the body can make estriol. Of course, it can make estriol out of estradiol. But we've been hearing this argument, Felice, for years from endocrinologists. Why give T3 when the body's just going to convert T4 to T3? Well, we're saying, well, let's just cross our fingers and say it's going to convert. And that's what he discusses in that 20-year update on ER beta. He says you don't just get conversion all the time, and you don't know from patient to patient. So why not give these agonists? And he lists a whole set of agonists, which is why because I had breast cancer 33 years ago, and I've been on bioidentical hormone replacement for almost 28 years, and I'm going to be 76 in a few months. And I've been diving into all of this for a long time because I want to keep myself safe and my patients safe. So things that signal ER beta are powerful. They're very powerful. And he investigated botanicals as well as hormones, as well as now he's looking for medication that acts like estriol for a breast cancer drug. So if the debate is, we'll naturally convert, we can't do what the body says, that's kind of in thyroid medicine for years, people said that. But ultimately, I just taught a 16-hour CME course on hormones with Dr. Brownstein, and he talks about the use of armor or desiccated thyroid or giving T3, because often the patient doesn't convert T4 to the active signaling molecule to the thyroid receptor, T3. And so I'm not sure that we can lean on that. And knowing all this and having studied with Yanaki and hung out with him for a decade over at New Orleans while I was trying to get gluten-free New Orleans foods, not easy to do. I kind of the heart, his work only strengthened my feeling that estriol is best added to hormone replacement, and especially since it's protective against multiple cancer cell lines.
But the difference is, I work with a lot of thyroid patients myself. I have thyroid issues. I have to take T3 only because I do not convert T4 to T3. So I'm very familiar with that. The difference is we can't rely on us converting T4 to T3 because not very many of us do it well. And when we don't do it well, we feel it. You hear it from the masses of hypothyroid patients. I don't feel good on T4. I'm still overweight. I'm still losing my hair. I've got dry skin. They have all the symptoms. Rather, you talk to a woman who's been on estradiol only versus a biased, you're actually getting usually the opposite, where a lot of the women on biased aren't getting all of the amazing effects from their estradiol because there's so much estriol in the mix. Rather, the women on estradiol are feeling amazing. And as you told me in our interview, Dr. Berkson, they're getting the breast protection. The studies that have been done on breast cancer and hormone replacement therapy have been done on, unfortunately, Premarin, number one, but now we have this 1 million study where they looked at all forms of estradiol replacement therapy, not biased, no estriol, and we see a reduction in developing breast cancer. So we
saw
know
this in
that it's
Finland.
safe.
In the Finnish study published
Right.
in ACOG in 2008, they looked at 125,000 women, and they found that estriol replacement, which is mostly used in Europe, was linked to the least occurrence of breast cancer. So we have other data too, just FYI.
Okay. Okay.
And
Also, to say
no.
that treating with biased works wonderfully for, but in fact, it's the only thing I've ever prescribed except for a brief hiatus in the early 2000s. So I would like to challenge you that women can feel wonderful on estradiol, but they can also feel wonderful
They can.
on biased.
Yes.
Absolutely.
Absolutely.
And the only other thing about estriol levels is to check estriol in the blood is very tricky because it's so evanescent. So you've got to time exactly when it's going to burst out there in the blood, and then it's going to disappear.
Okay.
That's why 24-hour urines are used for assessing estriol levels in young women and in women in menopause.
Got it. Dr. Gersh, you wanted to say something?
Well, I think that we need to really make a distinguishing thing here between treating breast cancer, because there's no question, and also certain autoimmune conditions, say multiple sclerosis, that maybe using specific forms like a SERM, selective estrogen receptor modulator, or also what they're now called estrogen receptor agonists / antagonists, because they work in various ways on different receptors, and they're used as a drug. So one thing is hormone replacement therapy, where you're trying to replace the hormones that the ovaries have ceased to make. The other is that you're treating a disease state of some kind, like whether it's like autoimmune disease or it is breast cancer. And I'm not saying that there can't be cutouts, carve-outs, where it may make sense to look at it as a therapeutic drug. But it is like, I have not seen any data anywhere published, and I'm totally open to seeing and learning. I am not fixed in anything in my way of doing things. I'm always flexible, that shows that there is a group of women that have some innate difficulty in making conversions between estradiol into estriol. Now, there is a definite issue when women are very inflamed. They have systemic low levels of inflammation, whether they're young and they're obese and metabolically unhealthy, that some people call metaflammaging, or they're older, and then we call that inflammaging, because chronically high levels of inflammation will impede the enzyme to convert estrone back into estradiol, and estrone is made significantly in an inflammatory woman in adipose tissue. And so that's, then they end up with this, what they call like estrone dominance, where they have a lot of, and then they end up in a state, that's very problematic. But really, when you look at inflammation, like you said, estradiol does reduce breast cancer risk, and it is very safe, and we need to get over this, cancer thing. I think nobody is thinking that here. But breast cancer creates its own estrone supply in the surrounding tissue to the breast cancer. And that's really that's why they give aromatase inhibitors. And Dr. Taguchi can talk more to this, that what happens in a breast cancer, it creates severe local inflammation in the area of the breast with the breast cancer. Of course, that's what triggered the whole idea of thermography, for what that is worth, but it's like inflammation detecting heat. So breast cancer creates a lot of localized inflammation, which then activates, upregulates the enzyme that converts androgens, mostly coming from the adrenal gland, like DHEA, DHAS, into estrogens, predominantly estrone, by upregulating aromatase. So breast cancer creates its own estrogen supply, which then activates the alpha receptor, which is the estrogen receptor positive receptor, but it's not just alpha. Alpha and beta aren't even one or the other. There are different, like we'll say, variants of the alpha and the beta. They're not just one receptor either. And so, then there's a new estrogen that's going to be coming out on the horizon, just to make people aware of it, estradiol. Estradiol is the fetal estrogen, also known as E4, which apparently doesn't activate the specific form of the alpha receptor that's found in breast cancer. That may be a unique use of that particular oddity, a fetal estrogen. But the bottom line is that a lot of the problems with estrogen really come from breast cancer and fat tissue and inflammation. And, the goal is to create that to block that inflammation in the first place, which is blocked by having estradiol. So I'm not anti the beta receptor. I love the beta receptor.
Yeah.
And estradiol activates the beta receptor and the alpha and the G protein coupled, all in a balanced state. So of course I'm pro beta, and I'm not anti-estriol either, but I'm very pro estradiol. And most people, and I'd love to hear this, I see lots of people coming into my office who have been treated with bias. And I'm not saying it can't be prescribed differently. I'm just saying what I see is that they're on 80-20 in most cases, and the amount of estriol that they're given is really minute. And I measure levels, I get 0, usually 0 or close to 0. So they're not getting hardly any estradiol. So they're not getting activation of these other really important receptors and variants of receptors, and the estradiol metabolites and the estrogen related receptors, and recognizing that it's not like alpha is evil. Alpha and the G protein couple, they're critically important, and they interconnect and everything. But most of the people I see that are put on the bias are not getting any estradiol to speak of. So they're really, really losing out on that. And they're not really getting growth factors produced, because they get no lining of the uterus growing. So if you're not going to grow the uterine lining, what makes you think you're growing anything? You're growing new brain cells, you're growing new cartilage and, collagen in your skin and everything. These are all really important, and we don't have enough research,
No.
So I'm a very simple thinker. I'm really a simple thinker. You know what? I can't be smarter than nature. I don't know what ratio is best. I know that if I give people the right nutrients, the right sleep, the right environment, I give them the right hormones that mimics what they had when they were healthiest, and then they'll probably do a lot better than if I try to create something that never existed in nature. And we really, if we know that estradiol, I'm not going to even go there right now. Okay. I know what blood levels are. I don't want to get into it. I know that the data does not really show, huge amounts of estriol in reproductive age women, but I'm not going to go there. But let's just assume that it is that the body converts a lot of estradiol to estriol. Well, then where's the data that shows that if you give estradiol, it's not going to do that? Where's the data on that? And by the way, thyroid is another whole story. A lot of people, just as a call out to thyroid, don't make the right conversion. Either they have antibodies, that's, Hashimoto's, but if they don't, usually it's because they have nutrient insufficiencies. You cannot convert T4 to T3 if you're deficient in zinc and copper and selenium and iron and all that. So it's often, just poor diet, nutrient, and gut and liver and kidney problems. All these other things.
Yeah.
you know,
yeah.
and all these
I don't
things.
think those
you know,
two can
but
really
I
be
don't think that
compared.
we can, that's exactly what I was going to say, Karen, that I don't think that we should just make an assumption that you have problems. Some people have problems making different conversions. So don't make the, you know, don't assume they can make it or they can't make it. But if you can show me that, you know, people are not making a conversion, because I have articles, I know I have articles that show that women will, in given estradiol in menopause, will convert, you know, to mimic what a reproductive age woman will convert estradiol to estriol. So I don't know of any data that shows that they won't do it. I don't know of that. But if people give biased, I'm just like begging them to give like a physiologic amount of estradiol too, not
Yeah.
this minuscule dosing, you know, where it seems like it's fear of estradiol that is really powering most people, maybe not you guys at all, but empowering most people to prescribe it because they're afraid of growth. They're afraid of growth factors. They're afraid of estradiol still. So at least if you're giving estriol, can you please give estradiol in a reasonable amount? That's my pleading.
Yeah. Yeah. Dr. Taguchi, did you have something to say on that? Oh, you're muted. Yeah.
Yeah, I know. Sorry. Thank you. I have the tree thing going on out here. I was just going, I just had some notes about the beta receptor and I know they're making drugs for the beta receptor. We have a drug called Avista, which is an alpha beta estrogen receptor. So we have drugs in use already for those kinds of things. The other thing too, and even if you block the estradiol, ER alpha and ER beta, you know, there's still the non-genomic G coupling or G protein coupling for the estrogen receptor. So it's a non-genomic, it happens anyway. So there's the body is really smart. Estradiol is super important. And what I was going to go back to, this leads me to the breast tissue. When somebody does have breast cancer, and I think this is why estrone was eliminated from the trias, was that breast tissue had a lot of estrone noted in it in the breast cancer specimens, thinking that was a cause. But we're back to how the body really needs to make it into estradiol to protect itself. It's all about coming back to the estradiol, or and estrone being potent too, but to help heal and correct itself. So that's how I see that.
Dr. Rosensweet?
Yes, believe me, I am a major fan of estradiol. When we look at a 24-hour urine, the very first thing I look at is there sufficient estradiol? Is there sufficient to protect the bones and the vagina? And these numbers are well known because when the pharmaceutical manufacturers first came out with patches and gels, they were trying to assess, well, how much do you need to protect the vagina and the bones? That's bottom line. And there's wonderful data, and we've actually translated it into the 24-hour urine. And that's the first thing I look for. If there's not sufficient estradiol and potent estrogens, then the woman is going to develop, most likely, bone loss and vaginal atrophy, not to mention the other tremendously important things to protect, such as arteries, brain. So I'm a major fan. I do think there is an underprescribing epidemic out there. I've definitely seen that. I see when I do the math to see how much potency is being delivered per day of whatever it is, estradiol or biased, there's a lot of folks that are underprescribing and not doing enough to protect the vagina and the bones. And it's an illusion to think that symptom relief will do it. We will do it. We personally conducted a study looking at the 24-hour urines of women who said, in my practice, who said, hey, I feel good. I found my right dose. And 75% of them were not on the right dose. 50% of those women were on insufficient estrogen, the potent estrogens, estradiol, to protect the bones in the vagina, even though they said they felt good. And 25% were on a level of estrogen that put them at risk for breast glandular cell proliferation, which is the upper limit. We don't really want to see breast glandular cell proliferation in a midlife woman. So listen, I'm a major fan of potent estrogens, my God.
Yes, you are. Definitely. And your course, really, you do come across as a big proponent of estradiol, I do have to say. Yeah, 100%. Dr. Berkson?
Well, you really want to know if your replacement is really anti-aging. Is the hippocampal volume, because the hippocampus is like the liver, it can actually revolumize. And exquisite research out of the Department of Psychiatry at McGill University took women who were frail, starting to become frail, searching for words, walking bent over, moving slower, couldn't go bend down and stand up. The same with gents. And they gave the women in this study an injection of estradiol and gave the men an injection of testosterone, and then tracked their hippocampus, which is where our memory and sense of self live. All these drugs that we're looking at to treat Alzheimer's disease, these drugs are supposed to protect the hippocampus. And they were able to show that if they had adequate estradiol, and I agree with you, you need adequate estradiol. We're not anti-estradiol just because we're talking about the benefit of adding estriol to it. We're not, and we're trying, sometimes you simplify things to kind of get across something rather than have a sea of words. But nonetheless, we want enough estradiol to protect the hippocampus, to protect the silent things like the basic cell of the heart, the cardiomyocyte, and the bones, etc. And of course, the vagina is kind of like a mirror into the brain. If your vagina is atrophying, your brain is not getting enough hippocampal estrogen. And the way that I track that, and I learned this from Anna DeRosa on my podcast, was she uses FSH, because elevated FSH causes many of the aging issues that even low sex steroids caused. In fact, a lot of pharmaceutical companies are making now monoclonal antibodies to try and fight brain fog, weight gain, bone loss by binding to FSH and making it unusable. So one of the things I do in my practice is track FSH. And if a woman's on hormones, whether it's estradiol or whether it's biased, but the FSH is still 75, 95, then she's not getting that hippocampal benefit. Although I want to do a study with functional MRIs, I really am hoping to do that over the next year or two. But that's what I'm using right now to give me a look-see or a feel that that hippocampus is improving, is if that FSH is going lower. And if a woman's on hormone replacement for 5 years, but her FSH is at 75, 85, 95, she's not getting that hormonal bang for her hormonal buck. Now, there's many other things to look at, but that's one of the ways I add that to how the patient feels, because you always want to also treat the patient as I know all of you feel. And I know you're all great practitioners, and we're just looking and sharing how we each look at something a little bit different from a different angle, and then why we do that. So I'm always trying to figure out, am I really getting their hippocampus protected? Am I really getting those heart cells protected? Am I getting the cells that line the arteries and blood vessels? And am I getting that bone protected? And so those are one of the things besides how they feel on multiple levels. Maybe that's a little bit helpful.
Well, that study, you shared that study with me. It's so fascinating because they found that it was 2 milligrams of estradiol that created that volumization.
But it was only a 3-month study, right?
Yeah.
We don't know if a smaller amount. That's why that study was
Over
only
time,
a 3-month duration
yeah.
of a placebo, 1 milligram, 2 milligram. And it was the 2 milligram estradiol equivalents. That's what they were very clear. It was estradiol equivalents, because you could also count for bias, which is 1/8 the potency of estradiol. So that would be put in the mix too. But it was only 3 months, and we really need studies, maybe lower doses over 6 months or a year, also get that same revolumization. But boy, wasn't that interesting that they could literally take where the piggy bank of memories live and enlarge it to have better cognition within
With
3 months, right? That's
estradiol.
incredible. Yeah.
Yeah. Now, does estriol have any effects on the brain, the heart, the bones?
David, do you want to talk about that?
Well, I never give estriol alone, and I'm a believer of, trying. And when the brain is at stake, when the brain is at stake, it's all hands on deck. And what I love to do is increase, as Lindsey was suggesting, the potency of the estrogen that's given, whether you give it as bias, whether you give it as estradiol. And how high do you get it? Well, ordinarily, I'm not a fan of getting period restoration, although there are major exceptions. And some of the exceptions are when a woman is going towards dementia and can get a full recovery And I know a doctor who this actually occurred to. So it speaks to the individualization and the individual need. And sometimes the need to really raise up that estrogen, even if the period does return. We can monitor other things. We can monitor overstimulation of breast glandular tissue, but getting the brain back is really of core importance to anyone who's losing it.
Mhm. Dr. Gersh, go ahead, Lindsey.
Well, just you were saying about the heart. So, you know, the endothelial lining, we all know that estrogen protects the heart, and women get more heart diseases. They have less estrogen. You know, they catch up with guys in terms of their vulnerability and risk. And 1 out of 2 women, in fact, succumb to the next incarnation, you know, due to an adverse cardiovascular event. But the major estrogen receptors on the endothelium are ER beta. There's more ER beta receptors on the blood vessels than there are ER alpha receptors, which is why Yanaki said it's a balance of both. But ER beta protects the heart like nobody's business, and there's massive data on that. In fact, I first heard about that by Jack Monaco, who's a gynecologist in Tennessee. I attended his lecture, and he was the first gentleman to start talking about that. And I called up Yanaki, who discovered ER beta, and he said, oh, yeah. And I had a long conversation with Dr. Yanaki Gustafsson, who I can hardly understand with his Swedish accent. And now it's got a little bit of a Texas accent tinged into that. Oh, I don't think he can understand a word I say, but we had a great conversation on it. And he went into depth about how estriol and agonists of ER beta are major cardiac preventers. So there's a lot of data, and the data just isn't known. I don't know why. And I remember going to Jack's talk that was sponsored by Biotics maybe 12, 13 years ago. So there is a lot of data on ER beta agonists, things that signal the second receptor. And mind you, estrogen's the oldest receptor on the planet. We've just now been learning about every single hormone has genomic and non-genomic signaling, and they all have different things that they do. But estrogen actually has about 14 or 15 receptors, and we don't even know what a lot of those receptors do yet. Some of them are just called estrogen orphan receptors, meaning we don't really, you know, we're looking to adopt somebody to have to get a baby in there that signals. So estrogen's extraordinary, and we will keep learning more and more. The hormone field is rather new-ish, but the other real deal is that there's many, our planet is encased in pollutants that act as endocrine disruptors, and they disrupt multiple estrogen receptors. So we're in a very new state. When hormone replacement was first introduced in Britain in the 50s and 60s, there weren't the same level of pollutants. We now see microplastics in sperm and placenta, and a healthy American woman's amniotic fluid is filled with anywhere from 150 to 300 chemicals that are all sitting on a lot of these receptors. So one hormone, the field of hormones is expanding rapidly, while at the same time hormones are under attack, and so they don't function as well. And there's now papers being written about endocrine disrupting compounds that literally attack the ER beta receptor versus attack the ER alpha receptor versus attack methylation capability. So it's not as easy to form that final protective set of metabolites that act almost like our natural chemotherapeutic meds. So there's so many interactions of things, and I bet over the next few years we'll learn a lot and maybe translate a lot of these into more optimal ways to write scripts for hormone replacement or recommend foods and nutrients for hormone replacement, because there's such a tapestry. But nonetheless, there are actually pollutants that signal out ER beta receptors and pollutants that signal out ER alpha and all the receptors. It's crazy. And one of the ways that ER beta is incredibly important in estriol is everybody knows about leaky gut, right? You don't want to have a gut that stays open and doesn't close appropriately after meals. Well, those adhesive proteins that they're like a sticky piece of bubble gum in between the enterocytes to bring a gut that opens up so nutrients can get into the blood and then should close so stuff that shouldn't get into the blood doesn't. Most of that is upregulated by ER beta. Now it's upregulated by ER alpha, also estradiol and progesterone, but a massive amount is upregulated by agonists to ER beta. So there is a lot of data on this. It's just not that well known because the hormone field is so newish, so to speak. And then at the same time, it's not well appreciated. Nobody talks about gender dysphoria and the role of endocrine disruption. But when I was at Tulane, one of our biggest questions is the gender bending coming down the road, because we saw in animals exposed to these endocrine disrupting pollutants that the males were feminized and the females were masculinized. And this was our major discussion. So we know that we've got a growing field of hormones, and we know we've got a dirty planet kind of assaulting and combating against them. So we have a lot of interesting factors, and I'm excited to see how things unveil in the next so many years.
Mm-hmm, mm-hmm. So Dr. Gersh, you didn't agree with that?
I can give you, and I'm more than happy to supply them, papers showing the incredible importance of estrogen receptor alpha for vascular function and vascular health. And of course, as I was mentioned earlier, the GPRs, or the G protein coupled estrogen receptors, are throughout the heart, and alpha and beta both very intricately involved in mitochondrial function. And in the arteries, there's a lot of complexity going on in terms of both the genomic, the nuclear receptor functionality versus the membrane, and a lot of them, the rapid effects, like creating enzymes, kinases like endothelial nitric oxide synthase, predominantly works through membrane receptor activation, which involves both alpha and beta. And so it's a complex array of things that are going on, but there's a lot of data showing that the alpha receptor is really a critical receptor for vascular health, and they're all important for cardiovascular health. And I think that, recognizing that, of course, vascular health has a lot to do with brain health. I mean, vascular dementia is extraordinarily common. Women suffer from Alzheimer's at a rate of 2.5 times the incidence of men when you age match them. So, and talking about like giving estradiol to the brain for cognitive function, is a really important thing. But just, like I said, I'm like pro every receptor, I'm pro every estrogen. I'm just looking to, like, how can you say that you should downplay estradiol by giving, ratios of 80-90% estriol, and then giving like minute amounts, you're just not going to create the effects on the different receptors, and they are in this beautiful synergy with each other throughout the body. So, if someone is treating something, or they really believe that you need more beta agonists than what you'd get from estradiol, though I have no data to show that anywhere, I'm open to seeing it. But, most doctors, like I keep saying, they give it at the expense of giving very tiny amounts of estriol. You're not going to get all of these amazing effects. And the research that came out originally involving the patch and all, it was all about symptom control. Really wasn't about health. It still isn't. There's no FDA use for hormones that's approved for health, for optimization, other than reducing symptoms. It's night sweats, hot flashes, and then vaginal hormones for vaginal health. That's and genitourinary syndrome of the menopause, which it's now called. But we are outliers, all of us, and that's why you're all part of my tribe, that we care about optimization of health. That's not really what the conventional world is prescribing for. They're really suppression of symptoms and short-term and low dose. And it's really important to know that there really is a dose effect. And I actually had talked about this some time ago with Dr. Taguchi of estradiol, that very small amounts of estradiol, which is what tends to be given in most segments of the medical world because of this fear that came from the Women's Health Initiative and still is just pervasive. Small amounts of estradiol are more pro-inflammatory, whereas high amounts are very anti-inflammatory. There really is a dose effect, and that affects also like cell integrity, so you don't have like metastases, and when you like lowering inflammation, so you don't have upregulation of aromatase and have overproduction in adipose tissue of too much estrone, and then get too much of the alpha agonist, because of inflammation from aging or metabolism problems and so on. But, there really is a dose effect, and giving too little estradiol is really not being incredibly helpful. It does suppress hot flashes and night sweats. That's the amazing thing, which is a blessing or a curse, depending on how you look at it, because it allows people to give minutiae doses of estradiol and still help people to feel, significantly better. But you really need, like everything, a dose. There is a definite dose effect with estradiol. And, there are beta receptors in the brain, there are alpha receptors in the brain, in the vascular system, the cardiovascular, in every organ. There's even ones that have a predominance of one or the other. It's always a blend. Like in the genitourinary system, in the bladder, there's a lot of alpha receptors, in the bladder for bladder function. And the muscles have a lot of alpha. And, there's like supplements that are, different phytoestrogens, and some are more alpha. A lot of them are beta, but like urolithin A is more alpha, and that's been shown to help with muscle growth. And that's actually an alpha agonist. So, I mean, I'm not anti anything, except I'm anti underdosing and undertreating and fear of estradiol. And that seems to be the pervasive use of bias that I'm seeing. And so I keep coming back to that, and like if you take the thyroid gland, just like the thyroid gland has estrogen receptors. It has alpha and beta. It has alpha and beta. You want a functional thyroid gland in the menopausal years, you need to have estradiol on board. So I just keep getting back to, estradiol is not something to be feared. It does micromanage its own receptors. It micromanages its own metabolites when you have the healthy body. So you can't just give hormones. I hate hormone clinics. I hate them where they just give out hormones and then they walk away, because hormones are necessary but not sufficient. No matter how you give them, it's not sufficient. You still have to do all the lifestyle things. You have to do everything from nutrition and sleep and stress. And like Dr. Berkson was saying, environmental toxicant, you got to lower your exposures, because, we're living in, I call it poison world. And that is true, So we do need to recognize, and when we look at breast cancer, which is a very feared cancer, and it's not rare. It's really common. Over 40,000 Americans die every year from breast cancer. I don't minimize breast cancer one iota, but who dies more from breast cancer? It's, older women, postmenopausal women who have a lot of inflammation, like obesity is one of the biggest risk factors for postmenopausal. And in younger women, it's mostly endocrine disruptors, like Dr. Berkson was saying, that interfere with normal signaling. And so, we just want to recognize that, the hormones that we give, the bioidentical, don't increase breast cancer, that chemicals do, disruptors for our hormones do. And that loss of our hormones is our biggest threat to health, loss of these hormones. And all I stand for is give them early, give them at physiologic levels, in somewhat like the way that women had them, rhythm. I know we maybe not have time, maybe another time, to talk about why I personally would always want women to have a period. Unless if they refuse, they refuse. I always give people choices, but if you keep giving small enough doses that you don't grow the uterine lining, then you're not getting all of your optimal growth factors everywhere. And, you're just not going to, you're going to have a suboptimal dosing. And, you have these rhythms, the beautiful rhythms of estradiol and progesterone and so on. But for some people, it's a deal breaker. If it's a deal breaker, it's a deal breaker. Then you don't do it. And progesterone downregulates estradiol receptors. So why would you want to give progesterone every day? That's not physiologic. It's not the way it's designed to be. But, I just wanted to, just no matter what people leave with from this like, get together here, this podcast, I don't want them to leave thinking that, nobody agrees, a hex on all of you, all hormones are going to be better than no hormones. We're still like, we need more research. I'm open-minded, but don't be afraid of estradiol. Don't be afraid of hormones, and get on them early.
But
And
people
stay
were
on them
starting to be
blind.
frightened of estriol. That was really one of the main reasons.
I never
Karen and
heard
I-
of anyone frightened of estriol.
No.
No,
Never.
I've been
never
hearing
heard that
it.
in my
I've
life.
been hearing it now in Facebook groups. I just was asked
Wow.
to be a reader on a book that's coming out in September. And the book, so just when we're getting our toe in the water of appreciating estradiol, and that the reanalysis by the original authors of the WHI showed if you were on estrogen for an average of 5 to 6 years, you had a decreased incidence of breast cancer by 23%. I've heard Dr. Taguchi talk about this even. And you have a decreased incidence if you do get breast cancer of dying from it, a decreased 44% fatality incidence. That's amazing.
on
But
horses
just as we're
estrogen.
getting it, people are getting frightened of estriol. So that was one of the impetuses of having this conversation to see what there was. Should women be frightened of estriol?
Well,
Should they be frightened of bias? So I'd love to have
The
that,
only thing, the only thing
chit-chatted.
about estriol that I would say is a worry for me is the fact that it does downregulate the innate immune cells, because high beta downregulates alpha. And that's just how it works. So alpha is the dominant receptor on macrophages, neutrophils, mast cells, the innate responders, which are downregulated in pregnancy for an obvious reason. But I don't want to downregulate them in menopausal women. We have COVID data. Women who are on estradiol during COVID, they actually fared better if they got, COVID. So I'm just worried about, how are we modulating the immune system with estriol? But, that we have no real data, that.
But that's kind of what's out there now, which is why it's great to.
Well, I mean, that's why
Varies like
I don't do.
1% of those, like you're, I know where you're getting that from, Dr. Berkson. I know the book you're talking about. This, trust me, I'm out there on social media on a daily basis. It is primarily, you're going to find that 90+% of hormone clinics are all about bias, and nobody's talking about a fear of estriol except for this little tiny group of people that are questioning it now. But I think the bottom line here is, and the big takeaway for all of the listeners, is that all of these amazing practitioners that I have here today at this roundtable have been in practice for over 20 years, 30 years for some of you, I do believe. None of you are seeing an increased risk of breast cancer, whether you're using estradiol or whether you're using bias. And I think that what we can all agree upon, which is the takeaway, is we just want to make sure that if you choose biased or straight estradiol, that you're making sure that your levels are getting to a therapeutic level that is going to protect your body. So if you choose to do biased, choose to work with a practitioner that knows your estradiol needs to get to a certain place, and your FSH maybe needs to get to a certain place as well, for you to get that bone, brain, and heart protection that we all want to see, the cancer protection, the breast protection. So would you not all agree with that?
Well said.
Well said. Hear, 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 hear.
Hear, hear. Well, I appreciate every one of you once again. I mean, we could have these discussions on so many different things. One being, which I'm not going to get into, but one thing that I wanted to talk to every single one of you about is the effects of progesterone cream versus oral, because there is a lot of controversy out there. I'm hearing so many hormone practitioners saying,
Mercola. It's Mercola's been publishing a lot of
and there's other
articles
people
that
I've seen, like really intelligent female hormone practitioners, doctors saying progesterone cream doesn't work, topical progesterone doesn't work, it doesn't protect the uterine lining. And I'm like, no, don't say that. And I've done podcasts about it, but I'm like, I need to talk to all of these people, because I know that all of you, I do believe, use topical progesterone. Do you not?
Both.
Yes,
Yeah.
same.
I
Yeah,
have
I
3
don't- I
different
use
delivery
both.
modes for progesterone. Sometimes I do it vaginal if there's pathology in the uterus, because
Yep.
that first vaginal pass is so great. So progesterone, delivery modes, how you get hormones into you can be utilized to individualize hormone replacement for the patient. But can I
Thank
just
you.
ask David, do you have anything else to say with that estriol just at last? Because you're like the king of
Well,
knowing about
I'm learning
estriol.
something on this podcast, and something I wasn't aware of is that I believe there's a distinction between those who are really doing expert work in not only alleviating symptoms, but paying attention to all the bottom line important stuff: arteries, brain, vagina, bones. And those who are afraid of estrogen, whether it's bias or estradiol, and are doing too low doses. And I have seen the too low doses, and I get to see it on 24-hour urine hormone testing, where the woman did get symptom alleviation, but her vagina and her bones, bottom line, not to mention her arteries or her brain or hippocampus. So the other thing is I did go through a phase of a couple years in the early 2000s when I was trying pure estradiol on my patients. And again, looking at 24-hour urines. And we didn't see anywhere near what Dr. Lemon found or I found, the level of estriol being produced. It's why I went back to biased. But both at the right doses, at optimal doses, at rich doses, not light doses, not endocrine light.
Endocrine
And
light, I love that.
no, rich, because these are the most powerful biochemicals in our body, and they have, like everyone on this panel has said, they're affecting everything, everywhere. So get it right, and people need to get that specialized training to get really good at these hormones, not be amateurs at it, because you can do damage with amateurs by amateur approaches to this, and not specializing in it. But oh yeah, enough estradiol, enough alpha. My God, you don't get enough alpha, you don't get enough estradiol. Someone's going to get hurt by that.
But Felice, I'd love to have that paper. Do you have that paper on how low dose is pro-inflammatory? I'd love to read that. Or could you email it to me if you get a chance?
Sure.
I'd appreciate that. Thank you so much.
Any last words from anybody else? No, we're good. Well, thank you.
It's an honor to be on. My goodness, I see the number of years represented by deep, deep, deep caring devotion to getting these hormones right. And I can just imagine when I think of Dr. Gersh, Dr. Taguchi, and Dr. Berkson, and you, Karen, the number of women on this planet that have been beneficially affected by getting it right. And I'm very moved. I feel very honored. It's a special time in history we have expertise of this magnitude.
Well, like I said, I've learned from all of you. You guys have been my biggest teachers in this field. So I appreciate it. And I hope to come up behind you with the same power that you guys have had in this space. So thank you.
And may I repeat that I appreciate the time and the time that you guys have been here together. I have learned a lot. And I mean, we're constantly learning. Every day is different. You can't rely on one thing. The data is always changing. And so if we can share the information, we're going to be better for everybody else. So thank you.
That's what I love, the open-mindedness that no one in this group is closed. Like we want to go with the data, learn and change as things evolve. That's the thing, and teamwork and, not getting rid of the fear, and I'm so glad that you brought up about, that there are so many people out there who just are doing something, but they're not doing it right. And so we definitely knowing what you're doing really matters in medicine. So, I'm just glad that everyone out there got to hear from all of us and see that life is not always black and white, and that we're all doing our best to try to help everyone out there.
I think we're all open-minded because we're hormonally balanced.
Yeah.
Good brain.
Our hormones are optimized. Exactly.
Brains are optimized. Okay, thank you so much.
Thank you.
Thanks.